and the jugular veins will be used as drainage cannula, but it occupies 3 veins related to complex tissue care, and patient will be bedridden. Something has happened.
Please click on the slide. Click on the slide, then next photo.
The meeting is recorded. It is written there.
Just click on your screen and.
Actually, what happening? There is a meeting is being recorded. I have to take a.
Sir, click on your slide, then next photo. It will automatically shift to the next side.
Actually, my actually the screen is locked, hanged.
Reshare it, sir. On share and then reshare it, sir.
Actually, my cursor is not working.
Yes, then the reshare, sir.
Okay. I'm continue. Okay. Now it is okay.
It's not coming yet, sir.
Okay. Now okay.
No, sir. No, it's not coming, sir.
It's not coming.
Yes.
Just hold on. Actually, you have recorded.
Yes.
Now it is coming.
Yes.
Okay. Actually, one started.
Yes.
Something has come up in the film. Okay. That femorojugular, it is definitely beneficial to do BB Ecmo through this route, because the access cannula, one of the drainage cannula will be in the femoral vein, the return cannula will be in the right internal jugular vein, and there will be no issues for the recirculation issue will not be there, and the advantages are nearly we will be able to provide 5 to 7 liters of blood per minute. The flow will be adequate in femorojugular route. That is the most commonly followed BB Ecmo pathway. And the most important, the gadgets is a double lumen 2-stage venous cannula, what we call it as Avalon cannula, that with a single cannula, we can get the return as well as the drainage. Both things can be performed with this Avalon cannula, but it is a costly cannula. We can use this, but this is a beneficial thing. We can, we can do ambulatory Ecmo by using this Avalon cannula. Coming to veno-arterial Ecmo, VA Ecmo, venous blood is accessed from the large central vein through a pump through axonate and return to the systemic arterial system in the aorta, either through a central arterial system or through a peripheral arterial system. If it is peripheral arterial system, mostly femoral artery, but there we'll have a retrograde arterial circulation and its complications also. The standard femoral arterial VA Ecmo, the advantages are provides full and partial cardiac support. Disadvantages are risk of differential shock. I'll come to all those complications later on. But the most common and easy way of doing veno-arterial Ecmo is femoral vein, the drainage cannula, and femoral artery is the for return cannula. Coming to the Ecmo circuit and components, definitely it involves a lot of things coming from blood pump, membrane oxygenator, heat exchanger, controller, tubing, cannulae. The Ecmo circuit, we used to use the common is centrifugal pump. Whatever you are using now is a centrifugal pump. The roller pump, what you know, we use in heart-lung machine, but here we use centrifugal pump. The centrifugal pump, how it helps us, it has a longer durability without having much damage to the blood cells, whereas roller pump, if you use, it has a more damaging effect if you use a patient on roller pump for more than 5 to 8 hours. But centrifugal pump also can deliver flow up to 8 liters. It is very reliable up to 21 days. Even people are using centrifugal pump Ecmo more than 50, 70 days also. What membrane oxygenator you do use is a hollow fiber polymethyl pentane membrane oxygenator. But in heart-lung machine, in CP bypass, we do use is a simple membrane oxygenator. Here we use PMP membrane oxygenators. It's extremely important to know about this because a regular membrane oxygenator we cannot use in Ecmo. This is very costly. The heat exchanger is very important component of Ecmo because the blood is coming out of body, getting circulated outside with the ambient temperature and returning back to the body. Definitely the temperature will go down. We have to maintain the heat. So every Ecmo machine will have a heat exchanger mechanism by virtue of which to maintain the oxygen, the temperature of our body. Is very important. This is a control panel. Everybody should know. Those who are involved in this Ecmo process, they do know how to run an Ecmo machine. But there are definitely tubings are very important part of this Ecmo circuit. Mostly we do use heparin coated tubings. These are pictures showing the cannulae, different long shafted cannulae, and definitely all cannulae are not as you think we do use in CP bypass. These cannulae are special cannulae. They can stay in our body more than a month or so. So will not have any bad effect on our circulatory system. But whatever regular cannulae we do use, if you compare, the cost of this cannulae are very high, and they are very durable cannulae. Coming to the indication and contraindications, as you know, as per the ELSO guidelines, Ecmo is definitely, it is considered if the mortality risk is 50%, but it is indicated if mortality risk is 80%, otherwise mortality risk is 80%. Before that, no patient should be subjected to this Ecmo modality of treatment. Ecmo is useful in reversible respiratory failure. Mind this word, reversible respiratory failure. If it is irreversible, then it can be used as a bridge to transplant or bridge to decision. In reversible respiratory failure like ARDS, severe pneumonia, severe acute asthma, chemical inhalation hypersensitivity pneumonitis, near drowning, post-traumatic long-term fusion, bronchiolitis obliterans, these are all indications. But for irreversible or chronic respiratory failure, there is no chance of reversibility, we can use Ecmo as a bridge to decision or bridge to transplant. There is no absolute contraindication for Ecmo for respiratory failure. But in fact, there are some relative contraindications, and particularly if the risk of this disease process is high, if FIO to more than 90% and ventilation duration is more than 7 days, and there is comorbidity is there, is patient in sepsis, and the absolute neutrophil count, if patient is in immunosuppression, absolute neutrophil count is less than 400 for cubic cc, and if there is CNS hemorrhage, if non-recoverable comorbid such as CNS damage, definitely terminal malady, these are all relative contraindications. We should not choose patients of this category for Ecmo. What are the inclusion criteria? How will decide to consider a patient for Ecmo? These are inclusive criteria. If you are finding these are important criteria, like in hypoxic respiratory failure due to any cause, primary or secondary, if 50% mortality is, that means PaO2 by FiO2, we will consider if it is less than 100, FiO2 with FiO2 more than 90%, a Murray score 2 to 3. If Murray score 3 to 4, definitely risk will be very, very high. Nearly 80% mortality risk will be there. And for if patient is retaining carbon dioxide and mechanical ventilation is not able to clear the carbon dioxide and the plateau pressure is more than 30, again, you may consider patient for Ecmo. If there is a need for intubation in a patient, a lung transplant list. If immediate cardiac respiratory collapse is there and because of pulmonary embolism, a blocked airway, because of acute myocardial infarction, if patient is not otherwise manageable, you can put patient on Ecmo. We should understand what is Murray score. Dr. Murray, who was enlightened about this scoring system, this is an average of all 4 parameters. This, if it is more than 3 or 4, definitely the risk will be very, very high. We may or may not consider patient on Ecmo. If it is nearly 2 or 3, even less than that, this score will be better. There is chance of recovery from Ecmo. Ecmo in cardiogenic shock, we can use VA Ecmo in cardiogenic shock for cardiac failure, particularly following myocardial infarction, following myocarditis, viral myocarditis, DCM patients. We can put patient on Ecmo either as a bridge to recovery or bridge to transplant. Yes, septic shock, though it was not initially considered for this group of patients to use Ecmo in septic shock, but now people are now started using, even in this category of patients, think of septic shock, Ecmo. The absolute contraindication for Ecmo is unrecoverable heart and not a candidate for transplant. Heart is not able to, it is not reversible damage, and patient is not a candidate for transplant. There is no point of putting patient on Ecmo. If there is a chronic organ dysfunction like emphysema, cirrhosis, failure, there is no point of putting patient on Ecmo. And prolonged CPR without adequate tissue perfusion, it is Ecmo, we call it as Ecmo. If it is used in CPR, we call it as eCPR. If noticed cardiac arrest in hospital, less than 30 minutes, maximum up to 90 minutes, you can use Ecmo in addition to CPR. If the duration is more than 30 minutes, definitely outcome is doubtful. There are some relative contraindications like anticoagulation, obesity, advances. What are the complications? Bleeding is the most important complication of Ecmo is bleeding, thromboembolism, cannulation related complications, heparin-induced thrombocytopenia, BB Ecmo, specific complications, BA Ecmo specific complications, neurological complications. Among these, bleeding and infection is the most important complications of Ecmo. And in BB Ecmo, we have noticed about 10% chance of intracerebral bleed. So before initiating Ecmo, we should make it clear with the family members that these are all complications. We have to understand that. I'm just switching all those points. I want to emphasize on the recirculation because this is the most common problem. If you are not very much confirmed that in BB Ecmo, if you are putting femoral root, the both cannulae, if it is within 10 centimeter distance, then there is chance of recirculation. We have to make the distance, at least the tip of return cannula and the drainage cannula, the distance should be more than 10 centimeter. Then only recirculation issue will not be there. Otherwise, there will be recirculation. The patient will not get benefit out of Ecmo. And there are other complications like in particular in VA ECMO, like pulmonary hemorrhage, cardiac thrombosis. Most dangerous complications of VA ECMO is cardiac thrombosis. Because ECMO, you are giving support, a retrograde circulation is happening, the heart is not able to pump blood from LV, is not able to pump blood through aortic valve. There will be stasis of blood inside LV. The blood will be, because of stasis, blood will be thrombosed inside it. This is most deadly complications of cardiac thrombosis in ECMO. How to manage this? We have to empty the heart as much as possible, and the heart should not be made fill at any cost. There are a lot of ways to how to make it always empty. And another complications of VA ECMO, specific complications, is coronary or cerebral hypoxia. Because in VA ECMO, in retrograde circulation happening, heart is some or other getting some blood from pulmonary circuit. It is pumping blood, and these bloods which has been pumped from the heart, it is not oxygenated. This is preferentially going to the heart itself through coronary, and preferentially going to the brain. So if the team members are not very much observant, they may miss this thing. The heart will suffer because of coronary ischemia. The brain will suffer because of cerebral ischemia. The most known complication and difficult complication is Harlequin syndrome or North-South syndrome. This is because of differential blood flow, and it can only be managed with a proper emptying the heart, proper maintaining the circulation or retrograde circulation through the femoral artery. Particularly, these complications particularly happen in a peripheral VA ECMO through femoral route. This is a picture how the patient will look like in Harlequin syndrome. Outcomes. As you know, ECMO in initial days, it was not very much encouraging. But in heart failure, with CHEER trial, it has been seen that it is helpful in patients of refractory cardiac arrest, where there is a need for reproductive arrest more than 30 minutes. If you are putting patient on ECMO, there is chance of survival. So we consider it as eCPR. We can make the patient survive by using ECMO. After that, the ECMO for cardiac failure, it has definitely come up to some expectation. But the landmark trial, the CSAT trial in 2009 for the flu, influenza flu, after the CSAT trial, ECMO has been revolutionized for use in respiratory failure, and people have started using rampantly for respiratory failure with some significant outcome, positive outcome of using ECMO in respiratory failure, particularly reversible respiratory failure. As I have already discussed about extracorporeal carbon dioxide removal or ECCR, when there is preferential carbon dioxide retention with a normal heart function, we can use the normal heart pumping function for the ECMO machine to remove the carbon dioxide. Again, the blood is coming back to our body. That is where the centrifugal pump of ECMO is not working, while the patient's own heart is pumping blood through oxygenator, and the carbon dioxide is removed, and the pure blood is again returning back to our body. That is ECCR. As I have already discussed of extracorporeal CPR or eCPR, what we call it as. But these are all clinical scenario we can use. But the most important aspect of ECMO is how to apply ECMO in clinical scenario. For that, it is not an individual game, it is a team game. And everybody should be very much knowledgeable, very much aware about the system of ECMO, very much involved in the process of ECMO. And the most important aspect of successful ECMO process is proper case selection. And every point of view, every time you have to
Just sorry for the interruption, slight interruption.
Yeah.
Can we conclude, because we are exceeding a lot of time,
Okay.
because
Okay.
we have got one more speaker afterwards.
Okay. Okay.
Just briefly summarize. That will be much better.
So initiation, maintenance, winning. Every phase we do give importance to ECMO, and most important is troubleshooting. If the person who is round the clock with the patient, like the perfusionist, he should have knowledge how to tackle the complications out of circuit, out of the machine, out of the patient. Circuit complications, troubleshooting, the perfusionist and the sitting doctor who is on duty should have the knowledge how to troubleshoot the problem. I'm just keeping those slides. As you know, the cardiothoracic surgeon, intensive medical officer, perfusionist, important player is perfusionist, respiratory therapist, technician, initiation. These are all important point. I'm just concluding because the time is. Yeah. What is the concept, the truism? Deployment of ECMO technologies is in the context of this medical futility generally results in futile deployment in technology. It is really the device. It is not the device which is responsible for the outcome. It is at what situation we are taking the help of ECMO machine. ECMO technology generally restores the physiology, but may not alter survival depending upon the specific of deployment. ECMO can support patients awaiting good clinical decision making. It is ineffective in supporting bad clinical decisions. ECMO resuscitates the moribund. It cannot revive the dead. Question of patient viability or myocardial recovery is always there. ECMO remains a non-durable technology. One day you have to remove ECMO if patient is not getting a transplant, choice is not there, or the organ is not recovering. It is non-durable technology. Is a simple procedure, extracurricular technology, or a complex management paradigm. Extracurricular life support accomplishes nothing. It accomplishes nothing. It is non-therapeutic, but it facilitates everything. I mean, it only support. Do not aim for success if you want it. Just do what you love and believe in, and it will come naturally. Thank you.
Thank you. Thank you, Dr. Mishra. I know it's a very vast topic and you have touched each and every point. And I request you to stay till the end. At the end, we have question and answer session. And I now invite our next speaker is our own Dr. Sarada Prasanna Sao. He is working here as assistant professor and he did his MCS also here. So he will talk about the ECMO in the scenario of COVID and what is the role of the surgeon. Now over to Dr. Sarada Prasanna Sao.
Respected Dean and Principal, senior faculty, teachers, CTVS, and my dear friends, good afternoon to you all. As we are in the difficult phase of this COVID-19 and where the patients are lying in the ICU struggling for their lives, and as we have lost many of our friends and relatives in the last 2 years, and particularly in this pandemic, the ECMO will definitely help in these COVID-19 patients to have some survival benefit. And the role of CTVS surgeons in ECMO in COVID-19 is as we'll go through these slides. 2019 novel coronavirus was renamed as SARS-CoV-2 and the illness is as COVID-19. This has become a greatest challenge across the globe. As we all know about the COVID-19, its clinical pathology, clinical pathophysiology, clinical features, related investigations, and the treatment also. I'm not going detail into it. So it is a viral pneumonia having started from the early stage, passes through the rapid progressive stage, consolidated stage, and then dissipation stage. And the related imaging studies shows that there will be patchy pneumonia, patches will be there, reticular opacities will be there. Then the burden of this pandemic. Out of the COVID-19 patients, 14% above 14 patients have severe diseases, and approximately 5% have critical conditions. And the case fatality rate is about 49%. And patient requiring invasive ventilation ranges from the 30 to 71%. Out of them, a small proportion of these patients require Ecmo support. As the pandemic has evolved, there has been steady increase in the use of Ecmo. According to the ELSO registry, that is Extracorporeal Life Support Organization, there are about 6,538 COVID-19 patients supported with Ecmo in the last 90 days, with hospital mortality rate about 49%, out of which 95% are on BB Ecmo and 5% are VA Ecmo. As Dr. B.B. Mishra has nicely narrated about the history of ECMO, I'm not going into detail. Only the first bubble oxygenator was developed in 1882, and 1916 heparin was discovered. The ELSO organization. During this pandemic, ELSO has formulated some guidelines. According to them, during the pandemic, ECMO service to be utilized for the maximum benefit, and it is based on the system capacity. It should be used where the outcomes are favorable and the runs are relatively short. The selection criteria should be more stringent to utilize this intensive mode of support. According to them, it may be divided into conventional capacity, contingency capacity tier 1, tier 2, and crisis capacity. In case of conventional capacity, where the system is running within capacity, we can use both COVID and non-COVID patient as usual criteria. In that case, extracorporeal CPR done only in expert center. But in case of contingency capacity tier 1, where system is running within expanded capacity, in that case, BB or VA Ecmo in selected group of patient, that is younger COVID-19 patient with only single organ failure. But judicious Ecmo use for non-COVID patient. ECPR is not offered. In contingency capacity type tier 2, in that case, the demand is increasing. In that case, we have to restrict the Ecmo use for non-COVID patient, and we should focus on the Ecmo, BV Ecmo in younger single organ failure cases. VA Ecmo and ECPR not offered here. In the crisis capacity, where the system is overwhelmed, in that case, Ecmo is not feasible both in COVID or non-COVID. We have to consider ceasing of all future care to create capacity in the system. So this is a difference between the natural lung and the membrane lungs in oxygenator. And the difference on the surface area, blood path length, thickness, and the oxygen and carbon dioxide transfer rate. On the right side, this is a Ecmo machine, and showing this is the membrane oxygenator, and this is the centrifugal pump. So this is the difference between the Ecmo and the CPB. CPB is cardiopulmonary bypass. Most cardiac surgeons, they do cardiac surgery with the cardiopulmonary bypass, and on the right side lower is the heart-lung machine. It is the oxygenator. In that case, the priming volume in case of Ecmo is very small, but in case of CPB is large. But oxygenator is for long-term use. Usually, you can use this for 14 to 21 days. It can be extended up to 30 days. But in case of cardiopulmonary bypass, it is of 8 to 10 hours duration. And all the differences are there. So type of Ecmo. It may be central and peripheral. Central Ecmo is done where the cannula put in directly into the heart, and the Ecmo is initiated. But in peripheral Ecmo, as Dr. Mishra has already told, so I'm not going to detail. Indication of VV Ecmo, particularly respiratory causes, ARDS both in COVID-19 and non-COVID, other causes being smoke inhalation, barotrauma, airway obstruction, asthma, and meconium aspiration syndrome. This is very important slide because This has been formulated, the guideline formulated by ELSO, where we have to take the P by F ratio into consideration. If the P by F ratio is less than 150, we have to manage with neuromuscular blockade and adjust the P, and inhaled pulmonary vasodilator should be there. Even after that, if P by F ratio is less than 60 millimeter mercury for more than 6 hours, or the P by F ratio less than 50 for more than 3 hours, or there is severe respiratory stenosis, this is a candidate for ECMO. Similarly, if the P by F ratio is more than 150 and there is severe respiratory stenosis, this is also a candidate for ECMO. The indication of VECMO, it is rarely needed in this pandemic, but however, it can be indicated in refractory cardiogenic shock, where if there is continual rise in the high sensitive troponin due to direct or indirect cardiovascular causes, pulmonary thromboembolism, and some cases septic shocks. Hybrid configuration. The VECMO relatively long, it is usually indicated in case of ARDS plus associated with any cardiac anomaly. Emergency conversion from the VV to VECMO during cannulation due to cardiac arrest are possibility were there, but it is not recommended due to exposure to the stuff. Contraindication of the ECMO: if the mechanical ventilation is for more than 7 days, age is more than 65, and the BMI is more than 45, and cardiac arrest with neurological injury, refractory acidemia is there, and if the patient is on multiple vasopressive drugs and thrombocytopenia along with contraindication to anticoagulation is there, or multi-organ dysfunction syndrome is there. Then cannulation strategy in the ECMO initiation. First, the cannulation consent. It is very important. The multidisciplinary team should counsel the family members prior to the cannulation about the procedure and the duration of stay and the outcome of the ECMO support. It is very important. Then ECMO cannulation site. On the right side, this is the ideal COVID-19 ICU with the ECMO facility can be done here. The designated, it should be done in the COVID-19 ICU with adequate space available, or it can be done in isolation ICU with minor OT attached to it. The team member is maximum 5, including the CTVS surgeon, cardiologist, intensivist, perfusionist, and staff nurse. All the cannulation team members should use PPE. AWAC cannulation is strongly discouraged. Before entering to the ECMO room, all the team members should have a checklist and COVID-19 sphincter bag containing all the cannulae, guide wires, heparin, and surgical instruments, etc. Then cannula. Sir has already told about the single lumen double stage cannula, and this next. These are the cannula, single lumen cannula and the double lumen cannulas. This is a video showing the cannulation technique.
You know, probably in Paris, in La Pitié-Salpêtrière, we have a mobile ECMO team, and we perform each year more than 500 ECMO implantations. So our team is very well trained with that. We go in a remote institution to put an ECMO for a patient, and after we perform the repatriation and the ECMO support in our institution. This is what we do for the COVID. We put an ECMO for the patient, and we perform the repatriation in an expert center in Paris. Considering the cannulation strategy, the cannulation is exactly the same that for all the other VV ECMO, and our gold standard is the femorojugular approach with some big cannula, 29 French cannula for the drainage and 21 to 23 French cannula for the reinjection, in order to have a very good flow support and to have a very
Following cannulation, the patient connected to the ECMO circuit with a lower flow rate, then gradually flow is increased and the pump started. When the desired flow is achieved, ventilator setting brought to the baseline. The tissue perfusion measured by the arterial blood pressure, venous oxygen saturation, and blood lactate level. Every 4 hours, the safety check is checked to exclude the blood clots and the circuit leak, and temperature maintenance is there or not. Vital monitoring, neurological and vascular status monitoring are also there. Respiratory system examination done, and the target should be there to FiO2 less than 50% to maintain of saturation 80 to 85. And the early enteral nutrition should be promoted. In case of hematological system, the target hemoglobin should 7 to 8 gram % and platelet count more than 50,000 and fibrinogen more than 100. If any procedure to be undertaken during this ECMO support, if bronchoscopy can be done, but it should be diagnostically and therapeutically indicated. Percutaneous tracheostomy, if done after calculation of the risk benefit evaluation. Early mobilization is to be done when safe and feasible, but patient should be able to maintain adequate neuromuscular function. Investigation. Blood investigation, activated clotting time, hourly done, and the lactate, CBC, electrolytes, and creatinine done twice a day, and antithrombin 3 estimation done prior to and 3 hours post plasma transfusion, and liver function test done every week. Screening ultrasound should be done to exclude any DVT of the both lower limb and the inferior vena cava, as COVID-19 patients are always hypercoagulated. X-ray test to do, done to see the progression of the disease, and echocardiography done to evaluate position of the cannula and the cardiac conditions. Winning from ECMO and decannulation. In that case, the sweep gas hit pressure is 0 to 0 liter per minute, and we increase the ventilator support as needed so that we can come up from the ECMO. Here, that tidal volume should be 6 to 8 ml per kg, and the PIP should be less than 16 centimeter water, and FiO2 should be less than 0.5. And the ABG pH should be more than 7.3, saturation over 88%, and partial pressure of carbon dioxide should be around 40, and oxygen should be around 100. If the gas exchange is adequate for 2 to 4 hours, then patient can be decannulated. So during decannulation, full PP precaution should be used, and we should be very much sure to avoid contact with the bodily fluids. Cannula that are placed by cut down should be surgically removed, and cannula that are placed by percutaneous should be removed as such, and bleeding controlled by topical pressures. Then complications are as already told, I am not going into detail. Then it is a pediatric and neonatal COVID-19. Expecting the third wave of COVID-19 in which the children are thought to be affected more, we must be ready to cater the ECMO service for them. Indications same as adult, and contraindications are severe developmental delay, lethal chromosomal anomaly, and extreme prematurity and low birth weight. Ethical dilemma. During pandemic, ECMO service to be utilized in younger patients with isolated respiratory failure. Patient selection and timing of discontinuation of the ECMO support poses significant ethical and moral challenges. ECMO should not be considered in patients with significantly reduced life expectancy. So, multidisciplinary team discussion with the family member before the ECMO cannulation is must. The take-home message is ECMO is a team support. Communication between the team member is crucial. Choosing the right patient is vital, and set the family expectation right away. It is not to forget that ECMO is a bridge to therapy, not cure of COVID-19, nor it's a magic bullet. This review of literature for ECMO, the meta-analysis of Caesar and Yulia randomized controlled trial by Ellen concluded that 90 days mortality is significantly lower in case of ECMO than conventional mode of therapy. Similar outcome was there by Lavina study, where they have taken 60 days mortality rate. This presentation is dedicated to departed souls of our ex-professor Dr. Chittaranjan Kara and about 800 doctors across the country who lost their lives during this COVID pandemic. I wish we all ACVians would be able to give justice to the COVID warriors as well as the people of Odisha in coming days as far as ECMO care is concerned. Thank you.
Thank you, Dr. Sarada. Now the floor is open for question and answer.
Thank you, Dr. B. Misra, for the beautiful talk, but unfortunately I had to intervene in between because of the time constraint. Our timing is 4 to 5, but it was really, really informative. And the time is always a big problem, you know. You are going so well, and I feel very guilty that I had interrupted. ECMO as such, even though in Odisha it started around 2.5, 3 years back, but it was not at all being utilized. I'm well aware of the fact that 2 of the Ecmo machine in some hospital and 1 Ecmo machine in KIMS, which was lying idle for a long time. When Professor Chitakara was in need of ECMO, the some hospital ECMO was not functional at that time, and the only ECMO available was in KIMS. There were a few anecdotal ECMO use prior to that. So with a lot of difficulty, with a lot of efforts, we shifted the ECMO machine from KIMS, invited, because initiation also is the most difficult thing, because in 2020, not many centers were very conversant with installation of ECMO initiation and maintenance. So we had to take a lot of trouble, invited people from Calcutta, they came, they helped us. Professor Kara was shifted. In the first wave, there was not much of demand of ECMO, if I can recollect. In the first wave, there was not much of a demand of ECMO. But in the second wave, the number of people requiring ECMO became so much increased. Almost every alternate day we are finding in the newspaper, appeal, and so on and so forth, that yes, people are requiring ECMO, it is a very costly affair, we may require 1 crore of rupees to start the treatment. So there was a lot of appeal through the media, electronic media and print media. Taking all this thing into consideration, many of the medical institutions, some hospital, KIMS, they started upgrading their ECMO unit. Government of Odisha took the initiative under the guidance of our Honorable Chief Minister, who is going to inaugurate our ECMO unit on 15th August. We are already in the process. Almost we are in the process of acquiring and completing the job. And we have been given target. We have recruited oxygenists. We have recruited anesthetists. So now the present time is very much in need of a ECMO installation, ECMO unit. And I'm pretty sure with this type of deliberation, the awareness, the utility is told to people. Till now, what we have heard is very disappointing information. When I thought of discussing about ECMO to Professor Chitakara, there was a lot of negative comments about it. Even friends from outside also say that ECMO is, and outcomes are not very heartening. And that was very deterring, and it was really very disappointing to a person who is trying to initiate a process to save a life. I have only one question, Dr. Misra. Well, you know that many a time there are irreversible lung damage because of variety of causes, and one of the major cause in the present time is a COVID-19 virus. Now, where there is no facility of lung transplant, one. Secondly, when we know that it is a irreversible lung parenchymal damage, how much this ECMO is beneficial to this category of patient? I am very aware that you have very clearly told the indication. But when it is single organ failure, it is only the lungs which is damaged irrecoverably. So how far it is justified to put a patient on ECMO because we don't have lung transplant facility? It is very less, insignificant in our country. This is a question to you, Dr. Misra, to highlight.
Yes, sir. It is a very important question. Rather, I would say ECMO, again, I would reiterate the fact that ECMO is a support system. It can only be helpful if the lungs or heart or both are reversibly damaged. If irreversible, definitely we'll have to think for alternative solutions like transplanting the organ, or there are in situation of heart or lungs, like artificial lungs also has come up, though it is not available in India right now. The PAL, the artificial lung, it may be helpful. And now also for heart, ECMO is not only for respiratory support, it is also for heart, cardiac support. For heart also, we can put patient, if transplant is not possible, we can put patient on mechanical devices like VATs which are durable. And yes, in India, it has not come up the lung transplantation program, but there are anecdotal report also. People have tried with the lung transplant, but all the more reason is important is proper care of patient on ECMO. We don't know whether lungs are reversibly or irreversibly damaged. It is too early to comment for a lungs to be irreversibly damaged. So keeping all hope for recovery, if a patient's life is given a chance to for a patient to be supported with ECMO, if there are some chance of recovery, and lungs, there are about more than it has an enormous reserve capacity. If more than 2/3 of lungs has been damaged, 1/3 of lungs out of both two lungs, if is functional, the person can survive with only 1/3 of lungs. So there are a lot of literature says that recovery or reversibility is there, though it is very difficult to predict in the early stage of disease process. Yes.
So is there any criteria? That is what exactly my pinpointed question. When we talk about single organ failure, you have mentioned about heart failure. Heart transplant also very few, very limited centers they do. We don't have an artificial heart. We don't have artificial lung available here as a device. Now, that's the question. What question is that? How far it is justified to go for a extracorporeal life support when we know at the end of it, we do not have any means to bring him back to the normal life?
Yeah. If you do know that there is very hardly any chance of recovery, there is no point. You are absolutely right. There is no point of putting patient on ECMO. That is why we have to select patient carefully.
Yes. But it has made such a hype as if that ECMO is going to save everyone who is having a COVID loss.
It is all media.
So big hype. That is what I wanted to point out. Any other person can give his viewpoint and ask questions.
Can I add to this, sir? What you have asked is a very, very pertinent question. And it's a hype in Odisha that ECMO is a magic bullet. If you put the patient on ECMO, the patient will survive. This is not like that. Also, the Gita of the extracorporeal life support organization, it tells that there should be a stringent criteria how to select the patient. It is not that all the patient you just put the patient on ECMO. If your facility is not there for lungs transplant, then how many days you can put the patient on ECMO? So initially in 2009, that H1N1, what the Caesar trial has told that, okay, you can put up to the maximum of 21 days. Now, as for COVID-19, there is a lot of dilemma is there. As you have rightly told, it's a very smart virus and you do not know, it's a very early stage. And people have tried, the results are there telling that up to 90 days maximum, you can put it. With that, if there is no recovery of lungs, and it's as rightly Dr. Misra has told, it's a breeze recovery. It is not breeze to anything. So
why, the main reason why I brought up this issue to be deliberated, because the cost involved in maintenance during ECMO.
Yeah.
Well, people have been requesting all throughout that my son will survive if he is put on ECMO. Now, the other thing, if you all know why the ECMO came to be known in our country. One of the senior most politician of Tamil Nadu, she was put on ECMO, and at that time, a British surgeon had come, cardiac surgeon had come to put the ECMO. So from there only we heard what is ECMO is in India. Now, any other questions? If anybody wants to give an observation or question.
I have a comment, sir. Rightly, you have pointed out, and perhaps you are the first man in Odisha to utilize these services for Professor Karo, and maybe I
I think that something is wrong. Something is wrong at Professor Panda's.
Sir.
Yeah. Well, have you come back,
Am I
Professor
audible,
Panda?
sir?
Yeah, now
Yeah,
it's okay.
Am I
Yeah.
audible, sir?
Yeah.
So perhaps that was the rightly you told in past Chief Minister of Jayalalitha in the Tamil Nadu. That was the incidents when Ecmo got known by
Known to
many.
outside world. Yeah.
But in Odisha, we knew after it was given
It's a
to
correct.
Professor Kara, and that you have started it first in Odisha, utilizing the system. And in our training program also, we conducted Ecmo training last year, taking the surgeons, cardiothoracic surgeons who spoke and detailed the facilities. But the issue is that like dialysis, if you see the artificial kidneys, previously we were designating hemodialysis as the artificial kidneys. And artificial kidneys were just a step in the preparing the patient for transplantation. But gradually that became a treatment modality. Now we have many shunters in PPP mode who are giving only dialysis, knowing that there is no transplant scope. Because
in other way, I think in other way, Professor Panda, if I put it end stage diseases, what we say, end stage renal disease, ESRD, end stage liver disease, ESLD, and of course, we can always put for the end stage lung disease. That part is there. But what is the moot point, what I was telling, are we really going for a hype, or really it is that useful what people think? That is the debate always.
Sir, I have a point. Sir, I have a point.
Yeah, that's a very important question, sir. That this is a support. Ecmo is just a support in preparing the patient for long transplantation.
Exactly, that is what I'm telling. Dialysis is a support, but transplant is the answer.
Sir.
Sir, I have a point.
Ecmo is a support, and the long transplantation is the answer now.
Longer heart transplant. These are the answer.
Sir, I want to intervene here. Say a little bit difference between this end-stage renal disease and this COVID-19 lung disease. Here, if you put the patient on ECMO, there is chance of recovery. If you give rest to the lung, there is a chance of recovery. I do not know end-stage renal disease. If you put the patient on dialysis, whether the kidney will revive or not. I don't have any.
No. Then you have brought up one very interesting issue. Professor Mahanti, just wait for a minute.
Sure.
This is interesting discussion going on. You see, you have brought it. Dialysis doesn't bring recovery excepting in AKI. Acute kidney injury, there is recovery. But when there is already CKD has set in, there is no question of recovery. It is a progressive disease. Now the question comes now. When the COVID affects the lung, there's a primary target organ is lungs, COVID, as of now, primary target organ. And when the pathogenesis continues in the lungs, unabated, what Dr. Misra told very rightly, 1/3 lung also, if it is spared, the patient can survive. So, unabated. This is from our experience. I'm telling, I was involved with Professor Chitakara's progress so keenly and so closely. I know what are the things that happened. Now, he became COVID negative, but his long recovery never took place. So, it is a damage. You have to make an assessment of the extent of the damage. If the extent of the damage, we are doing so routinely his evaluation, the chest X-ray, the HRCT, we are doing so regularly. Both the lungs are solidified. They are all solid lungs. There was no scope of an alveoli existing. If I remember correctly, if FiO2 was 100 and PEEP was around 14, 16, we are worried about the barotrauma. How do you make an assessment that still there are some alveoli which can be recruited, some alveoli can recover in function? Dr. Misra, any methods to know?
Yeah. So I'm giving a reply to this. Actually, you have rightly pointed out, sir, that 1/3 of lungs is sufficient to get a recovery and a normal life. But it is very difficult to know whether that 1/3 is still there or not.
Functioning or not, yeah.
But whatever the pneumonia process, whatever the ECMO support, it is a continuous process. ECMO definitely carries lot of other issues like initiation, maintenance, weaning. Every step is a continuous process. It's not like simple dialysis. It has other complications like bleeding, sepsis, infection, multi-organ failure. All the things may happen during the process of ECMO. And all the more reason, any patient we are putting on ECMO, for example, first patient we have put a VA ECMO in 2017 in KIMS. That patient I have operated post cardiotomy. Patient had developed heart failure because of RV failure. I had to take the help of ECMO in 2017 December 7 in KIMS, expecting that RV will improve, but it is a chronic RV failure, didn't improve. Patient survived for 17, 18 days, but could not be vented out because of lack of facility of heart transplant. If heart transplant would have been there, we could have saved that child. It is a 17-year boy. But the thing is this, ECMO is not a simple process. It's a very complicated and definitely it requires a lot of involvement, multidisciplinary involvement. And for example, we are continuing with 4 ECMO patients in our institution. One of them is more than 34 days. A lot of issues are happening collaterally, infection. But how to cut short those issues? This is very, very challenging. Proper monitoring, proper case selection, proper monitoring, aseptic measures, everything matters. Then only the outcome would be expectedly better.
Naturally, the second subsequent questions follow up of this. The question which was raised by our colleague also, how long we should wait? Because, you talked about recovery of the lungs. How long we should wait? Just putting somebody patient in ECMO is not the answer. That's the beginning. That is not the end. So when to end? When you can confidently say, yes, the lungs are better. Hello. Somebody, I think there are minimum decency and courtesy some people are forgetting. Keeping their things unmuted and they're unnecessarily disturbing the proceedings. Anyway.
Yeah, the other way around, sir, this is a hope for life.
No,
like
no.
From general ward to ICU.
I'm talking in perspective of COVID.
Sir.
Till now, whatever patients have gone on the ECMO, you tell me one example. There are few anecdotal, but many of them from the state that we have sent.
I know only two persons walked out.
Yeah.
Only 2 persons till now.
Is it the timing of ECMO?
Yeah.
Or is it the timing by ECMO? That is the most important thing.
Yes.
Don't allow the lungs to undergo further damage.
Yeah,
I think very nicely presented that. Anyway, Professor Mahanti.
Sir, I have a question that our discussion is on the use of ECMO in respiratory failure and cardiac failure and eCPR. But in our setting or in our place, there is a lot of cases of poisoning and snake bites. The application of ECMO in snake bites and in this poisoning is very rewarding. Lot many cases in Bangalore and in New Delhi and some other cities have shown very good results in the application of ECMO in toxicology. What?
When you said about snake bite, it has a reason to it. Or poisoning, when you say. You are talking about respiratory failure, you are talking about cardiac failure. Which one? You must specify. Just don't say poisoning.
Mostly cardiac, sir. What Professor Mahanti is talking.
Yeah.
In toxicology, the indications are cardiovascular, and it has a rewarding point
right.
because they are reversible situations.
Because you have got a mechanical ventilation for the lungs. So I don't think ECMO is at all an indication for the respiratory problem. It may be for the cardiac problem. Anyway, so I think that is one other indication Professor Mahanti said. I think Dr. Mananjan Behra has been on the line to give his viewpoint.
Namaskar. Sir, I must
We'll have only 2 more questions because it's already 5:50.
Sir,
Yeah.
I must thank Dr. Vanudhari Mishra for his excellent presentation. Sir, one thing we are hearing that after subjecting to ECMO, some patients are developing other organ. For example, acute renal failure. What is the incidence of acute renal failure? Yes.
No, I think this has been already told. Only very recently also Dr. Mishra told about the problem associated with the ECMO during maintenance of ECMO. And one of the things has already been mentioned, AKI. AKI can be because of many reasons. In a ECMO, to point out it is because of the ECMO, it is not possible. Dr. Mishra, anything else you would like to add?
Yeah, you are rightly answered, sir. Because in ECMO, there is lot other issues we have to take into account. Like organ function depends on ECMO itself is an extracorporeal circulation which is non-physiological. With non-physiological blood flow, if loss of pulsatility in via ECMO will definitely may hamper the kidney function. One. Second is ECMO related complications like infection and the maintenance of hemodynamics. If it is deranged, definitely it will affect kidney function. And the incidents, I have no idea about this because I cannot comment on this because it is too early experience we do have. Definitely I would like to comment on the toxicology part, what Professor Mahanti has commented, that be it snake bite, be it poisoning, these are all, as long as the poison is inside body, it is hampering our cardiac or lungs or both functions. If you give some support, giving rest to the organ, definitely there is a high chance of recovery. So patients who are on reversible heart failure, reversible lungs failure, the chances of recovery is high. So definitely toxicology patients, we do also take the help of ECMO, particularly oleander poisoning. We have taken up one patient in Kings. Unfortunately, that patient, we could not make it because of other issues, because that patient also a sickle cell disease patient. So ultimately, we have to lose that patient in 2019, if I'm not wrong. But
I think let's go for any other observation, queries.
Sir, I have a point, Dr. P.K. Jana, pediatric surgeon.
Yes, please.
Till now, we have discussed so many points about ECMO and COVID. But for pediatric patients, it's a very, very positive thinking. You see, for last 30-35 years, ECMO is used in pediatric patients. 2 conditions I will quote. One is CDH, congenital diaphragmatic hernia, where all types of ventilators have to rescue. Aspiration syndrome, the survival is 100% because the lungs recover. In pulmonary congenital diaphragmatic hernia, we use ECMO and wait the lungs to grow. So how much they will grow, and we do not know. So the long term, 2 months, 3 months, sometimes ECMO is used till the diaphragmatic hernia can be operated or the lungs can recover. So these are
but
the
next consequential question will be, Dr. Jana, in a congenital diaphragmatic hernia, how long a child can be put on ECMO?
Sir, there are stringent selection criteria. The criteria is very, very strict. It cannot be used in a child who is less than 1.5 kg and so many other things. So
and how long?
Is very, very
the question is how long?
2 months, 3 months they have used. It's a very, very costly affair.
Anyway, I think last question will be by Dr. Suvapada. He had surfaced.
Yes,
Again gone.
sir.
Yeah.
Sir, namaskar, sir. So
Namaskar.
this is more of a technical question. Since AKI is quite common, in particular using ECMO, what I have seen my training in Canada in bronchiolitis and meconium aspiration syndrome. So what you used to do there with ECMO with CRRT. So is that a separate machines or same machine can be used since you are coming with 6 or 9 ECMO machines to the SCB? So this is much easier technologically if you use ECMO CRRT compared to conventional CRRT. You just need a diversion of blood from the main circuit.
I think the first question that will arise now with your first observation. You want to divert blood to two machines?
No, sir, not two machines. The same machine, same circuit. Small amount of blood is diverted. Each patient develop
Yeah,
AKI.
Because
Other than
particularly in children, I think you are very aware that what disastrous effect it can have if the extracorporeal volume becomes more. Anyway, give your observation again, please. You wanted to say something more.
So, sir, is that like separate machines or same ECMO circuit can be used for ECMO CRRT, both purpose?
Now, I think I do not know. Nobody has knowledge about CRRT along with the Ecmo. Nobody has an experience. Whoever is present here, if you know something,
Sir.
tell it.
Yeah.
Sir.
Yes.
Yeah.
Actually, Dr. Shubal.
Go yeah,
Yeah.
go ahead.
Actually, to my knowledge, our first patient in SOM Ultimate, we have put a very young patient, the very first day patient, because of pre-existing sepsis, went into ARF. And following putting patient on ECMO, patient needed renal support because there's a lot of acidosis and lactate has gone up. We thought to connect patient on CRRT. We do have CRRT with us, we thought, but we could manage with SLADE. Two sittings of SLADE, patient recovered from sepsis and antibiotics, high up antibiotics, improved, stayed in our hospital for more than 26 days, has been transferred for further management to higher center. But with our experience, we do have CRRT. We can connect the patient on ECMO CRRT with the venous circuit to be connected, and the blood will be purified, and it is a continuous process. And SLADE, we can do in both ways. But BB ECMO in COVID scenario, because of normal heart function, normal pumping function on the heart, it is not much of challenge. But BA ECMO is always a challenging situation to go for renal support system.
Why I'm
Beautiful. This is a very good discussion. I think this is the most interesting part of all the discussion we had. You know, that's the biggest challenge. As you have rightly pointed out, AKI is not that uncommon in a patient on ECMO. And in that case, if there is a rising trend of renal progression, renal deterioration, how to handle those situations? But the fact again, the basic question comes, this is non-COVID. What we are discussing is non-COVID. Am I correct?
Yes.
When it comes to COVID, and when we are anticipating irreversibility in the parenchymal damage. Anyway, but this is very good discussion. I think a lot of time has been consumed. One more time we are getting for the discussion on ECMO. I think anesthesia department is coming up with a follow-up discussion on ECMO. They are also going to present on ECMO. With these few words, I again hand back to our Professor Patnaik for the final conclusion and vote of thanks.
Thank you, Dean sir, and all my esteemed colleagues who has come here and attended and participated in this deliberation. We have learned much from this discussion, and at the end of the day, the vote of thanks, I request my assistant professor, Dr. Sitaranjan Fatoi, to vote of thanks. Over to Dr. Fatoi.
Respected Dean and our teacher. I'd like to thanks to our distinguished speaker, Dr. Banubihari Mishra and Dr. Sarada Prasanna Sahu for their excellent presentation and making this session interesting and meaningful. We feel it is our great pride and honor on this day to thank to all our alma maters who play the great role in making what we are now. So we give thanks to our respected Dean and Principal, Professor Dr. Tatesh Rota, for welcoming this session on ECMO.
I also like to express our deep gratitude to our professor, Dr. Manoj Kumar Patnaik, for moderating this session. I also like to thank our all senior faculty teachers and all SCVians, all senior and junior teachers for participating in this webinar. Thank you.
Okay, thank you all. Signing it off. Hope meet you later. Thank you.